Hello, everybody. Thanks everyone for joining. Glad to have you guests today for this webinar. I am here with two of my very close friends, Harry Jha, Saurabh Jha, and Kent Hutson, both of whom are radiologists who I have been in practice with before. So when they tell you their experiences, I can call them out if they're lying. Very glad to introduce Harry Jha, professor of radiology at University of Pennsylvania, who is his claim to fame is he is probably the most famous radiologist on Twitter, formerly known X, formerly known as Twitter. In addition to his multiple awards, laudatory comments, and incredible personality. So he needs no introduction from me, but very, very well known to the radiology world as our health policy expert and international guru for all things radiology. Ken Hutson is a radiologist who I've worked with very closely, incredibly talented, not only as a radiologist, as a deep night teleradiologist, which, given my background, I always find super admirable. But actually, he has a special talent, which is he is a computer science expert and coder. So he understands what goes on behind the codes and algorithms that we're going to be using in the future in AI. So Kent is at Radiology Partners. He is Director of Innovation, AI Innovation, and he is a certified physician executive as well, and a leader at Radiology Partners in all things AI. Radiology Partners is the largest practice in the United States, so obviously a very, very important person there. For those of you who don't know me, I am now the Chief Medical Officer at Qure for the last 6 months. The last 15 years I've spent in multiple large teleradiology groups, beginning with Nighthawk in the early days, going to VRAD, then Rad Partners, and most recently at Envision Healthcare, where I was a teleradiologist, practicing teleradiologist, and physician executive. I started using AI probably 6-7 years ago in the earliest forms of NLP at VRAD, and have continually been involved and impressed by the growing capabilities. So, what we're here today, now that the introductions are out of the way, to discuss are generative AI and LLMs and their use in radiology. I kind of wanted to start, since I know you guys aren't spring chickens, you guys have been around, this is not your first rodeo. I wanted to talk about dictation in general. And, kind of my history with it was that I had an alternator, I had a dictaphone when I first started reading. And, the majority of my career has been with what most of us use, which is voice recognition software. And I wanted to start with that as a basis. Pros and cons, comparing the two. Did you guys ever use dictaphones, or was your whole career with voice recognition? I'll start with Harry.
Thanks, Samir, for the introduction and invitation. I was one of the transitional people that went from dictaphone to voice recognition, and my opinion of voice recognition hasn't changed much since then, which was that it was not very helpful. The major reason voice recognition worked in radiology is because the reports got to the referring physicians much sooner than they did with dictaphone, because the dictations would be in batches. So here's one technology which is widespread adoption, which hasn't made my life any easier. And those who remember the dictaphone days know that it was much easier. Now, there may be some satisfaction in getting the report as soon as possible, but I thought that could have been circumvented by having more labor, more 24/7 labor, rather than the scenario that we're in right now. It's all very good. It's great technology, it's very impressive, but as far as making my life easier, it failed to do that. I've now gotten used to it because we get used to, you get used to people, get used to technology. It's like a marriage; you have to maintain it. I'm not saying that it's like my marriage; it's like generally a marriage. But you adapt. But it's not, it didn't save me from the abyss or anything. In fact,
Yeah,
it took me closer to it.
I agree with that. I'm gonna let Ken weigh in. We trained together, Harry and I, but like honestly, it's the problem for me has been that my job hasn't gotten easier over the years. You know, my workload has progressively increased every year. You know, especially in teleradiology, it's just the list gets longer and longer. Ken, how about you? I don't know your training. I know you trained at Baylor, right?
Yeah, well, so when I started, we had cassettes and handheld cassette recorders, and you would dictate a batch, and then you would use a rubber band to tie up the requisitions, and set the tape and the requisitions up on in a basket, and then somebody would come around and take it to the transcriptionist. So moving to a system where you have the dictation going to a central server and transcriptionists being able to access it, that was a huge leap forward. With VR, the approach that we took, we had VR and you used it, but we still had transcriptionists. So there was an option to where if it had messed up a lot, then you just hit, you sent it off for them to fix it. So the radiologist wasn't burdened with having to edit the report themselves.
And they had audio of
right,
what you.
right. So the transcription had the audio; they could go through there and fix it. And we found that about 80% of the studies could be signed off without having to send them to the transcriptionist. So those studies got much faster turnaround. Typically, the more complex ones, the ones the abnormal ones, where and you see them now when you dictate that. Still, there are transcription errors. Even today, this is 25 something years later, right? Which is crazy. Those ones that had errors, those are the ones that ended up being delayed because they had to be sent off to get fixed. As we progressed, the transcriptionist, it became more and more difficult to justify having transcriptionists, and so they eventually started disappearing. And so then the burden fell on the radiologist. And so I agree with you that at the point where the radiologist becomes the editor and has to go back and correct their reports because their system is failing to properly transcribe it, that's a negative impact on the radiologist. And you could argue that maybe overall it's a good benefit for the for the patients because we're getting faster turnaround times, and that is true. But you also have to look at the efficiency of the software, the system you're using. If you can fix it, why not fix it? Why not make it work better? So I think that's at the point we are now, where we need to fix it so that we remove that non-interpretive burden from the radiologist again.
Yeah. I mean, for me, I never saw like voice recognition for me didn't get better and better and better. I had to adopt. I changed my style completely, and I want to stay on this topic for a few minutes, just the early few minutes, because it does set the stage for where we are today. Because no question, when I was at RSNA, the big topic was: is voice recognition going to change now? Or we hit a new crossroads with generative AI. And when I think about it, I think of how I had to adopt macro driven, which was not necessarily bad. I definitely appreciate the less cognitive burden that when I'm editing and trying to look at images, etc. So I definitely shifted myself, but I never saw voice recognition improve year after year. It's kind of been the same for me for 20 years. And I just want to know, Harry, how about that aspect of it? Especially because you have a British accent. Is there any kind of, do you have good recognition? Have you had stable recognition? Has it been not so good?
No, I had to change the way I speak. I sound more like you now. Voice recognition changed me.
That's not a
No,
good.
I mean, there's nothing from it. There wasn't much of an improvement. There wasn't. When you say there was some, I didn't notice any, and there were some words just was stubbornly refused to recognize. And the whole thing about using macro, the standard templates for various description, it's fine to do that, but it really makes everything. It forces uniformity on shades of grey, which not everything. There's a macro that people use for aortic valve calcification, and it's like aortic stenosis, and there's a reference. Yeah, it is, but it depends on how much aortic valve calcification. If there's a little speck and you use it, and you say the same thing as if there's a lot, then you're not using your judgment. And the bit about cognitive burden, I mean, that's our job. And that's why we're human. That's why we're human beings. I'm not sure that escaping cognitive burden is good for us
Right.
after all the training and the MCATs and everything else. If all we're going to do is just regurgitate macros, then quite honestly, AI should take our jobs. I'm looking
It's
forward
not
to it.
often enough. It seems like our culture has moved towards, how fast can you be? How many macros can you have? Rather than like, it used to be an art to learn what language to use, especially for Harry and I, Kent, Kurt Langlotz impressed upon us, and many of our attendings impressed upon us, like what language, like what descriptive word. When you say consistent with, you imply X, Y, and Z. You might want to say in keeping with it. Like these language things were very important. I don't know. What's your opinion, Ken? Did you have the same experience training?
Yeah, and another good example is what is unremarkable? What does it mean to say that something is unremarkable? Well, you shouldn't have remarked about it then. So, but yeah, I agree. And the templates that I use, I don't go in nearly that much detail about individual findings. So yeah, I think that you do have to hit a balance. The idea of being able to just dictate what you want about a given finding and have that information placed into a report in the proper place, so that you don't have to spend time looking over at your report and seeing where you need to put that dictation, put that phrase. That's the kind of improvement in reduction in the non-interpretive part of dictating that I think we need to focus on. As we move from dictating the entire report, start to finish, every little bit, towards being able to just look at the report and say, yeah, that's correct. That's the progression towards lean dictation. So where you're using fewer and fewer words and really just using the words that are needed to describe the important stuff. The abnormal findings, the things that you as a radiologist need to express to get into the report, without having to dictate all of the extra fluff. What are the comparison studies? What was the history? The system should be able to generate that stuff for you and present you with a reasonable first draft proposal.
Yeah. So I want to shift our conversation now to what's been going on, given that perspective, and I wanted to put you both into that mind frame of talking about, your history with dictation and how, it's a massive part of our lives. It's what we do. And you guys are both, no question. I chose to talk to you two because of the influence you have over radiology, radiologists, and everything else. When you think about generative AI now and LLMs coming into radiology, again, I point to RSNA. There was a lot of buzz with these new companies that kind of started with natural language processing, and now the big buzz was generative AI to help radiologists make impressions or structure their reports or even generate their reports. Tell me, what do you think about this? From the 30,000 foot level, what's happening with that? Harry, you first.
Yeah, I'm going to quote Shania Twain. that doesn't impress me much. And the reason is that, yeah, on a kind of computational part, it is impressive that LLMs can generate reports in the style of Donald Trump, but that's not useful to me. And I don't want LLMs to dictate my impression. I don't need that. That's my job, and I don't need any help in that. I don't need LLMs to give me better structure to my report. I can do that. Thank you very much. What I do need AI to do is to improve the speech recognition so that there are fewer to zero transcription errors. And this is the problem with AI and people in this field, is that they want the cars to fly, but they can't even ride on the roads. So first learn to ride on the roads and actually be helpful before coming up with fancy stuff, because most of that is completely useless. And the reason it's completely useless, at least for me and many people that read like me, when I look at an imaging study, I decide what the patient has, I decide if there's a differential diagnosis, and then I also decide concurrently how sure I am of the diagnosis. If I am very sure that the patient has lung cancer, there is no point waxing lyrical about it. Lung cancer with mediastinal adenopathy without adrenal involvement. There's no point getting Shakespearean about it. If I'm Shakespearean, it's because I don't know what I'm looking at. And in that sort of situation, the uncertainty is not going to be reduced by AI. So similarly, if I see a chest x-ray and I think the patient has severe pulmonary edema, I'm going to say severe pulmonary edema. I'm not going to say peribronchial cuffing and para-alveolar opacities. That's great if you're a medical student. It's good to know what the findings are, but I'm far removed from that. And also, people think that waxing lyrically on reports will save you from a malpractice suit. It doesn't. If you missed, you missed. It doesn't matter how many paragraphs you've written. If you missed a finding and it's significant, you've missed it. And if you haven't, no matter how briefly it takes you to write it, you're not going to get sued. So it really, this thing about where you must first take a finding, describe all the borders, and enhancement pattern. That's not necessary. You decide. We've trained, we've read, we've been tested in our minds. We know what we should be looking for, and the referring physician never really calls me and says, "You called it a hemangioma. I want you to convince me it's a hemangioma." They don't do that. In fact, it's quite the opposite. It's when you hedge that they come back to you and say, what exactly are you thinking? What's going on in that little brain of yours in the dark room? So I'm sorry, I don't need any help from ChatGPT, LLMs, and I certainly don't need my impression generated. Thank you.
Okay, so that is not a equivocal opinion. That is a strong opinion. Kent, what do you think about it? I mean, Harry is saying, there's no question that this is not going to help him. He doesn't need ChatGPT to make his impression for him. Well, how do you respond to that?
So I do use a product that takes the findings that I've dictated and generates an impression. And I do find that that's helpful most of the time. Most of the time I'm reading ER stuff, so it makes it a little easier. Where it fails is when there's a bigger cognitive leap from the findings to the impression. And like you were saying, Harry, that when I do an impression, I like to just say, lung cancer, not go into all the little details in the impression and all that. And the systems currently that create an impression for you from your findings tend to regurgitate things if there's a big cognitive leap between findings and impression. So I agree with you on that. I will say that the area that I see LLMs helping us the most when it comes to interpreting is not on our report itself, but it's in digesting the EMR and previous radiology reports so that we don't have to spend the time digging down through them to find, there was a questionable adrenal nodule, from 3 years ago, and I'm seeing it now. Was it ever there before? That's a very common question, right? Was this finding somewhere before? And so being able to data mine the previous radiology reports using LLMs and also the EMR, I think is going to be a game changer for us when we're doing our interpretations. The EMR is something that radiology traditionally has avoided because it's just difficult to get into it and to extract data from it, even if you do have access to it.
Especially remote, and you're reading from different sites and different hospital systems. Can't do it.
Exactly. And you can get valuable information from that. It's very, very common for me to get a study from the ER and abdominal pain, something vague like that. And then when you dig back through the previous reports, and you find, oh well, they had colon cancer, and so now you have some more information to be able to produce a better report. Why don't we have our our AI systems going back and doing that data mining for us and presenting us with succinct histories and radiology oriented problem lists so that we can do a better job of what we do?
Yeah, I mean, Ken, my last shift, it was just abdominal pain. It was not. It's kind of shifted. It's the majority. Like, oh yes, I got a few trauma for sure. That helps. But just abdominal pain does not help. Harry, what do you think of that? Like, I was going to shift the conversation to that specifically. Like, ChatGPT can help me not spend as much time digging through priors, trying to figure out, more history, et cetera, et cetera. Can it be the detective for me and get the data?
Yeah, I mean, I have to agree that anything that summarizes those hideous electronic health records can only be advantageous. And if the LLMs can do that, that's great. And also if they can send a parallel report to the patient that uses non-medical jargon, that's also quite useful. But the idea that we kind of need this contextual information is also very contextual. Kind of, It depends. Do you need this information? Depends. If a chest X-ray is stone cold normal, you can tell me whatever you want about the patient. That's not going to change my interpretation. It's normal. If a head CT is normal, it's normal. If a belly CT is normal, it's normal. If there is a 50% pneumothorax, very little can be said that's going to change the 50% pneumothorax to, oh, well, now that I go into the EHR information, I'll reduce it to 10%. Now, there can be scenarios where you might find out the etiology of the pneumothorax, which you should be looking for anyway. But in terms of the idea that the contextual information changes what you say is true, sometimes, maybe more often than we think, but if in many situations it doesn't. The next thing is that when you're reading the frequency of chest X-rays that are read in the intensive care, if you're reading for the ICU with people getting 3 to 4 chest X-rays a day, anytime they move the NG tube, they get a chest X-ray. Having a snapshot of the EHR appear in front of you every single time is just annoying. It's like
Overload.
It's like a monkey on your shoulder. And studies have shown that when you give radiologists contextual clues, including AI clues, it slows them down and worsens the performance. So you have to be very careful on how it's used. I think having a summary of the EHR for 30 X-rays that I might read in an hour, I will end up smashing the machine like Ned Ludd. And you know why he smashed the machine? It wasn't because his job was threatened. It was because he was whipped to work harder and harder. People got that bit of the Industrial Revolution wrong. So the thing is, it can be useful. When is it useful? Well, I presume it's useful when you have somebody who is an oncology patient that has opacities and you want to know where the radiation was. But that's very nuanced. That you can't just dredge through the EHR for that. In many ways, you have to think like a physician to be able to think what's useful. And if LLMs can do that, I will appreciate them. But until then, keep them away from me. They're useless.
So I'll tell you, my experience with using an LLM kind of impression generator, I did a lot of oncology. And your first reaction is, this thing is not going to work. It is not going to be able to take the nuance. But I'll tell you, many times, the nuance somehow, almost magically, would appear. So basically, I think it has to do with how many reports it ingested of mine, but basically it would come to a conclusion. Like, so with an oncology patient, it would tell me, like, my impressions, usually the first thing I'm going to say is there progression? Is this worse? Is it stable? Or is it better? And I would tell you the LLM did that for me. And it would actually, I'm sure it depends on how the LLM is programmed and what organization you're using. And the reason I'm going along this is because I want to know, do you need a company to make these LLMs, or can we all use free chatbots? Because I'm telling you, the day is coming when everyone's going to have access to the most advanced, specific chatbot that's free. You can do it today. You can put your radiology report in a chatbot and create a structured report, and even it'll give you an impression. What I'm saying is, when I say nuance, if you're dictating an X-ray and you say cardiomegaly, effusions, pulmonary edema, the impression should be decompensated acute CHF. I've seen some glimmer of brilliance in some of these LLMs, Harry. It's done that job for me. It's definitely doesn't work all the time. You have to edit, but it also has some flashes of brilliance, especially in the drudgery of oncology reports.
I think that you have to kind of firstly distinguish between the brilliance of technology, which no doubt is brilliant, but also the usefulness. Something can be brilliant but not useful. And for all the Hollywood 3D effects with Avengers, you can't make a movie like the original Top Gun with all the emotion and the drama. So there are some limitations to technology. The point here, on your two specific examples, is that I'm really unable to get excited by its usefulness. If my oncology report says unchanged, 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 and then it says no evidence of progressive disease, I'm like, wow, that's not terribly useful. I could have said that in 10 seconds. What would be useful is it actually took the nodule, found it, gave an imaging number. That's the bit which is irritating. Gave the imaging number, gave its morphology, compared it to the previous study, gave the image where that was present. That is where I need help. Or I would appreciate help. I'd pay for something like that.
A massive shout out to Qure, because that's exactly what we're going to be doing. But
fantastic.
Yeah.
The other thing is that the other example you mentioned is the pleural effusions, okay, you can say curly B lines and you can say radiating para-alveolar opacities, but I don't do that. I've stopped doing that. There's no point. If I think the patient has acute decompensated heart failure, I'll just say it. Nobody's asked me, you said that there was severe heart failure. Did you see curly B lines? Because I read about them in a medical textbook. Nobody's asked me that.
Right.
So it is, again, it's sexy, exciting, and it will certainly excite a lot of people that come from a dinosaur generation, but it's not useful. That's what I'm saying. It's
no. I appreciate the way that you're being very, very direct and cutting through any.
There's no point. You knew there was a risk of that if you invited me. So
that's true. Ken, what do you think?
Well, we talked about LLMs, large language models, but the next step are the large vision models, which combine the language and the images. So those kind of models being trained on, let's take the chest X-ray example. Trained on the chest X-rays and the reports. So when you have these lean reports with kind of the minimalist impression and that don't go into deep description of all the findings, if the system is trained like that, then that's what it's going to get to. And so given a choice between having to dictate the report versus having that report drafted based on the vision model, seeing the chest X-ray and giving me a report like what I would have created based on that, that speeds me up, right? That gives me a report that I just have to approve. So it's kind of like having a resident, pre-dictate your reports for you. And throughout all of this, I think what we need to focus on is trying to reduce that non-interpretive part of our job. The things that we do that don't have anything to do with looking at the picture and deciding what's wrong.
Right. Which is what Harry's saying, practice at your license level. Tell me, the nuance of the film, not the drudgery of the film.
Mm-hmm.
So I agree. What about the fact that this is potentially universal now? Like, not only universal, I'll go one step further. Even the monitors we buy, we work in institutions where, monitors can be thousands of dollars and are kind of controlled by certain companies in industry, just like the voice recognition is controlled by certain companies in industry. And we're almost getting to the point where certain companies own the PACS environment. Are we going to be seeing, and I'm talking about because we have Gemini, Bard, ChatGPT, Amazon Code Whisperer, are we going to see a day when, you have an Apple set of glasses, you've got voice recognition through ChatGPT type things, you've got advanced voice recognition because you have Siri or, Alexa. Are we entering a time where we're free of hardware constraints and location restraints, and we're going to see that is going to drive change in the way we work? It's a little bit off topic, but it's actually related because I think this is going to drive some changes in the industry.
So yeah, I'll start with that. So there are
a person to start because Kent is an expert on peripherals, on mice, keyboards, anything you use to do radiology efficiently.
So and it all comes down to the user experience, the radiologist user experience. What is it like to work as a radiologist? Let me start with the VR notion. VR, for those of you who have not used VR, it does take time to get used to it. The technology, even with the Vision Pro, is still more of a tunnel vision sort of thing. And I've spent a lot of time in VR, working with VR, and I think it's going to be a little while longer before we're ready to use it as a radiologist. And it does take some adaptation to be able to use it. So separate from that, I think the radiologist user experience can be a lot better, should be a lot better than what it is now. And the systems that we're using now, for the most part, they're, like you said, you have somebody who has a lot of the VR market, you have somebody who has a lot of the PACS market, and they all quote work together. But when you sit down as a radiologist and try to use all these things together, that it's the user experience is not as good as it could be, is not as seamless as it could be. And that means that you have to do a lot of extra work to make things happen the way you want them to, to make it easier to work. So I do see opportunity with the newer open source models that we have coming out. They have really great speech recognition open source models out now. Large language models open source now. That gives companies the opportunity to kind of take the hard part, if you will, and then start putting together into a cohesive whole that makes for a better radiologist user experience, and not relying on the few big players to do everything for them.
Harry?
Yeah, I have to admit your question is a little too futuristic.
It is.
But I guess you really wanted me to shut up, so you asked me something that. But if you, there are multiple things that drive technology adoption. Sometimes it's just thrust down your throats, like the EHR was, because of some grand vision of Obamacare and value-based healthcare. And sometimes you pick it up yourself and you say, look, I want this. And that's essentially what happened with PACS. It was self-evident. Nobody did a randomized controlled trial to see if PACS was useful. And PACS was an enabler. Thanks to PACS, we could do thin section coronary imaging, because you imagine on the hard film, if you had to put 3,000 images up, what that would have been like. And then there's of course, the Palm Pilot, which was people just adopted it because
Yep.
all of a sudden you didn't have to carry books with you all over the place. And the best example, I guess, is GPS. It was self-evidently useful. And as time went on, firstly, there was independent GPSs, then in the car itself, and then now nobody sells a car without a GPS because you know that people say, where's the GPS? It's like we expect that. So are we going to get there with some aspects of AI? I mean, I expect we will. I think once it breaks through, once people start lapping it up, they wouldn't want to give it back. That's the sort of stage you need to get to.
Yeah.
So the problem that you have in getting to that stage is twofold. Firstly, you guys need to make money. That's understandable. And we need to get paid, right? And
Yep.
between our pay and your money, there's a very little thin sliver that you can, very thin amount of fat that can be trimmed. And even
Right.
trimming that fat can have problems because then we'll get paid less. If CMS finds out that with AI reading the chest x-ray, radiologists can read 3 times as much, what's the first thing they're going to do? They're going to say, let's revisit these codes.
Yeah, it's
So,
why reimbursement down with tax.
So it's going to be a zero-sum game. It's not that easy to, the pie is not going to increase for everybody. Maybe a few early adopters will walk away with in the sunset, but most of the rest it'll equilibrate, and there is a big risk that AI, through its promise of increased efficiency, will make lives worse for radiologists in 10 years' time. The radiologists will be reading more for less, feeling more burnt out, more like a hamster on an efficiency machine, except somebody's pushing the hamster. Hamster's still running as fast as it was. It's not as if radiologists are going to leave at 4 p.m. and go and do yoga and all of that stuff. All that's going to happen is they're going to read till 5. They're just going to read 3 times as many studies.
I was hoping that would be the golden period again, because when I started training, you did go play golf at 4 p.m. and it was a known stereotype that the radiologists didn't work very hard. They took an awful lot of coffee breaks, etc. But literally, it's the exact opposite now. I mean, we are the ones who are constantly working, and other physicians tend to leave the hospital before us.
Well, you have to think of it, if you think of it historically, there's no technology that has come in radiology that I can think of that has reduced my workload. None.
None.
None. Now, you would think PACS did that, and PACS certainly reduced the strain on my deltoids by putting this stuff on the alternator. But thanks to PACS, I'm reading far more images than I ever did.
Yeah.
The images are getting thinner, and so the visual, my occipital cortex hasn't been given, hasn't been left, hasn't been relieved for years. And I think there's a big risk. If history is to repeat itself, then there's a big risk that AI is going to just make things worse in the long run. I don't think it's going to replace radiology. It's going to make things worse. Now, let's just look at that chest x-ray thing. I actually want AI to read the chest x-rays. I think the way we read chest x-rays, there is zero inferential value of the chest x-ray. It used to be this, very majestic thing, but people get a chest CT, so you got the answer anyway. And also you get a chest x-ray every 6 hours. So all you're looking for is delta and a pneumothorax and a tube in the wrong place. That doesn't require 8 years of medical training. It's fine.
Yeah.
So let's just say that the AI reads a chest x-ray, and I now have to look at every single chest x-ray because the radiologist needs to be in the loop. For that one error that AI, statistically speaking, is certain to make. Essentially, I'm a TSA agent now. Now, rechecking. How is that useful? Either you take it completely or you get out. This radiologist in the loop just doesn't work. So again, I think you've got to, if you look at AI historically in comparison to other technologies, it doesn't seem very optimistic. I'm not seeing any transformation out there. I'm not seeing the Garden of Eden. I'm seeing a gate that leads to another room in hell. That's really about it. I am in hell, and AI is another gate that will lead to another room in hell. It'll be like, welcome to hell again. Sorry.
Interesting. I mean, especially for somebody my age to hear this, because I did have training that like the chest X-ray was the ultimate, art. It was art to dictate an X-ray, right? And what you're saying is let AI take it because there's no art left in it. It's not.
The art is redundant. The chest X-ray was an art because if you saw a 40-year-old who's never had any imaging, and you say, "Oh wow, this is undiagnosed tetralogy of Fallot," that doesn't happen anymore. Anybody with tetralogy of Fallot who has an interesting X-ray has 50 cross-sectional imaging prior to that. But the diagnosis has been rendered so many times. The X-ray isn't even a historical curiosity. So the X-ray, the unknowns of the X-ray have been killed. And let's say you're reading serial X-rays, serial portable X-rays. You're looking at the lungs. There's an opacification in the upper lobe, now in the lower lobes, now in the upper lobe again. What are you going to say? You're going to say, "Oh wow, that looks like mycoplasma pneumonia." No, you're just going to say the disease has progressed.
Mm-hmm.
You're not good because you've got all the answers in front of you. ID is already there with a battery of tests screening for every known organism known on this planet. We're in very different times. And the chest X-ray, unfortunately, has lost its magic.
Kent, so Terry made two comments there, obviously 2 points. One about the reimbursement system. It's going to catch up. It's going to make, we're not going to have this golden age. I will tell you that I did have a medical student say, I don't want to go into radiology because you guys work way too hard, right? Like when we were going into radiology, nobody said that. Nobody. Are we going to be that way? Ken, how do you respond to his first part? And then how about the second part that like basically chest X-rays should be reading themselves?
So on the first part, yeah, when we talk about when PACS came along, 30 years ago, when the rise of DICOM and the ability to create PACS systems to be able to view things more efficiently, it made us more efficient, but there was still more and more demand. Along with that, separately was more and more demand for radiologists to read studies, more and more studies to be read. And so I don't think we can blame the technology for that. I think we can blame our healthcare system for the increased utilization. So I agree. When we get to when we start talking about studies that are relatively low impact, that have relatively low risk of being interpreted incorrectly, if they're interpreted incorrectly, like the chest X-ray on an ICU patient, then it doesn't make as much sense to have a trained radiologist having to spend their time messing with that, spend their time on that. Now, how does that impact the reimbursement? I'm sure it's gonna come down. There's going to be some changes in that. It'll probably take a while for those reimbursement changes to happen.
How much is a while? 5 years? 10 years?
I think probably 10 years. That's just because but I do see that at some point we're going to have to make decisions about, okay, what kind of exams are relatively low risk that we can accept that that some percentage of them are going to be misinterpreted. That's just a fact. Some percentage of studies right now are misinterpreted by radiologists. We're humans; we make mistakes. AI is going to make mistakes also. It's just the magnitude of
we'll be much rougher on AI than we are on our fellow colleagues.
True. And I think that in general, our philosophy should be, okay, what is the risk if we know that we're not going to be performing at 100%? We never will be. But what are the things that we can do that we can accept to a lower accuracy rate, knowing that, and just accept that higher risk. And I think that's the ICU chest X-ray is a good example where probably we can accept a higher error rate there.
I mean, a lot of radiologists will argue against that. They'll be like, "That's crazy. We need a radiologist to read that ICU X-ray." Harry?
Yeah, well, the radiologists are very internally inconsistent. They complain about burnout because they're reading too many, and then when you offer them solutions, they're like, "Oh no, not that. How about this? Oh no, not that." All right, go ahead then.
Yeah.
With regards to the AI being held to a higher standard, I don't think it's necessarily held to a higher standard. It's just that you can sue a radiologist. You can't presently. There's no legal framework to sue an algorithm. If there was, then the lawyers would be like, "Yeah, bring it on. Let's wait for that tension pneumothorax that AI will statistically miss." And then it'll be
Right.
on the developers and the hospital to figure a way that it gets reduced. So it's not, all the things in the United States are driven by money. That's why I love this country. It's extremely capitalistic and transparent, and it's rather emotionless. Even the emotions are driven by money. So if you can sue the algorithm, it'll be all of a sudden very acceptable. Until then there will be all this dance around who you can sue. Now, the other point you made was the part about the why wouldn't radiologists give up AI? And here I think radiologists need to just sit down and understand what they're facing. So I know it sounds like I'm very much against AI. I'm not. I just wanted to be helpful, rather
Yeah.
than wary of the increases in efficiency. Fact of the matter is that imaging is going to keep increasing because of advancing age. People are going to live longer. And no amount of preventive stuff is going to get rid of chronic disease. I mean, this is just a pure lie that people peddle. If only you were doing yoga and breathing, these ancient Indian techniques, you'll live longer. That's just bullshit. People will get cancer, they'll get amyloid, they'll get neck of femur fractures. And once they get cancer, they get drugs for it, which creates its own. Every disease known to mankind can be caused by oncological drugs. So the imaging volume is not going to decrease. People aren't suddenly getting smarter with their clinical acumen. So that's going to increase. So radiologists have a choice. Either you mass produce radiologists, which has its own issues. Firstly, you need to find the training program, or you offshore work. And you have two options to offshore work, either technology, AI, or extenders. And the last time I mentioned extenders, people kind of, went cataplectic. But show me another option. Either you mass produce radiologists and have as many radiologists as, by the way, if you want radiologists to be reading, keeping up with all the imaging studies, including the DEXA, including the fifth portable radiograph, because the NG tube has been moved by 3 centimeters,
Right.
you're going to need more radiologists than you need family care physicians. And firstly, it's going to be impossible to produce that many number of radiologists. Secondly, if you do, what do you think is going to happen to radiology salary? It's going to reduce drastically. And any technology then that can take 30% of your workload is going to throw you into unemployment cycle. And all of a sudden, medical students won't touch radiology with a bargeful. It's happened before. It can happen
Yes.
again. And so the radiology community, particularly the excitable young physician section, need to sit down, not give bullshit about it's about the patient or any other mindless bromides, and say, look, what is your solution? Because we have a increasing volume problem, a burnout problem, and we're not going to keep up with the volume. So what is your solution? Let's hear it. There's a silly slippery slope argument, which is that, once the AI takes a chest x-ray, then very next thing they're going to be going for diffusion weighted MRI. I mean, if that's the level of confidence you have in your professional skills, then maybe you should be replaced by AI. I'd encourage that.
That's a great note. Very, very, very well said. Kent, anything to close our remarks? Believe it or not, the time has kind of gone by. We've answered most of the questions that people have been asking. Believe it or not, we've covered quite a bit. From the spectrum, from reimbursement to the future and what we think is going to happen. Kent, how would you give me your closing statement here?
Well, I think the what it comes down to is us using the tools, AI tools, and remember, AI is nothing but a computer science tool. It works better on some of the problems that we haven't solved yet, but it's still just a computer science tool. Use those tools to make our job, help us work better. And when we say work better, more efficiently in a way that is where the whole job experience, the user experience, is better. And I think that's where we need to head. The arguments about replacing radiologists and all those, that you still have to have someone who is responsible, and you have to have someone who is capable of higher level thought processes than what you can train an AI model to do at this point. Mm-hmm. By the time we get to the point that an AI model can outperform a radiologist in general, our entire society is going to be changed.
Everything is going to change by that time. I agree with that. Like, people are like, what do you think? Well, ophthalmology is going to be totally different. Surgery is going to be different. Medicine is going to be different by that time. So it's just like no concern about that. I think that's a good note. We are, 9 minutes left in the hour. But I think I'd like to get us out of here early if possible. Anything else to conclude, Harry? I think we've had a nice discussion.
No, I apologize for my cynicism, but I've just spent the morning reading portable radiographs, and honestly, I can't wait for AI to take this over. I'm begging AI. Where are you, AI?
Yes, I hear you. Yes, there have been some remarks about your cynicism in the chats, but that's okay. Again, there was a rationale to having you here and to cut through some of the flowery views of AI and just like get right down to it. So thank you guys. I really appreciate it. It really was a very nice conversation with two visionaries. I view you guys as visionaries. Very hardworking radiologists as well, so you guys can have a lot of credibility. You guys walk the walk and talk the talk, and I appreciate it on behalf of Qure. Have a great day. Thanks everybody for joining. This webinar is going to be recorded and available to everybody. And talk to you soon.
Yeah, thank you.
Thank you.
Thanks. Take care.